YouTube पर I think
just finishing the setting.
Okay.
Yes. Yeah, so we are live on the YouTube. We wait for a minute or two.
Sure, no problem. It will be around 45 minutes, 30 to 45 minutes.
Yeah, that's good. You can speak for 40-45 minutes.
Yeah.
We'll have 10 minutes of discussion still left.
Yeah.
We have Dr. Harish Baria in the audience. He is a pediatric intensivist at the Children's Hospital.
Okay. Nice meeting, sir. Good morning, sir.
Harish?
He is muted.
Nah, he's not.
Yes, sir. Good morning.
Good morning, sir.
જગદીપજી તમારે ત્યાં કોણ ઇન્ટેન્સિવિસ્ટ છે PICU માં?
We have not appointed one as an intensivist.
Okay.
Yeah.
Is in pediatric, we have like fellowship in critical care from Indian Society of Critical Care Medicine. So is there anything such official, some college which gives this kind of courses in pediatric?
In pediatrics, there are fellowship programs.
Okay.
Accredited with the critical care chapter of IAP.
Okay, fine. So similarly, we have also Indian Society of Critical Care Medicine, which since many years it gives fellowship in critical care. Right. But nowadays in adult, even DM critical care is also there. So after few years, this all will be. So this is official MCA recognized. This the other one is private kind of courses.
Yes.
So since few years, this is recognized by MCIN as a super specialty.
Yeah, we don't have DM or critical care yet. So we can start the program. Good morning, friends. Welcome back to Saturday Club morning meeting. And today we have our guest speaker, Dr. Ankur Bhavsar. He had given a talk a year back on rational use of antibiotics, which was very well appreciated. Today we'll have him talking about fever in ICU, and a very interesting topic. And to briefly introduce Dr. Ankur Bhavsar, he is head critical care unit, Spandan Hospital, Vadodara. And he had his critical care training at a very well-known Hinduja Hospital in Mumbai. He is instructor for ACLS and BLS. And his main areas of interest are antibiotics, ARDS, sepsis, and fluid management. To his credit, he has 20 years of experience in critical care medicine in adults. And he is founder member of ISCCM Vadodara. And obviously, he has been invited as a national faculty in various conferences. So with this brief introduction, I request Dr. Ankur to go ahead with his talk about fever in ICU. We'll have about 40-45 minutes of talk, and we'll have 10 minutes of discussion. So over to you, Dr. Ankur. Thank you.
Thank you, sir, for kind, generous introduction. I'll share the screen now.
Yes.
So I think it is visible.
Yes. Working well.
So morning, everyone. I'm privileged to talk to a very well-known pediatrician and very senior physician and consultant. Basically, fever in ICU is one of the very sometimes nagging issue where whenever we goes for round, we always see, oh, there is a fever. What should we do? So we have to evaluate that fever in very elaborative manner, whether it is really infectious or non-infectious. We can't just bombard them with the antibiotics without knowing the source and the etiology of the fever. So let us see how should we evaluate the fever in ICU. Next slide. Sorry, yeah, next slide is not happening. I don't know why. Okay, yeah. So initial impression, whenever we see the fever, could be infectious, as I already talked. Either it's infectious or non-infectious, and it could be a continuation of etiology for which patient is admitted to the ICU. So many patients are admitted with some etiology with fever. So I'm not going to talk about the PUO. I'm talking about the fever, particularly in the ICU. And sometimes ICU have its unique etiology for the fever. So first we start with the sir. I think there is some disturbance going on. Is it something needs to be muted if possible? Background. Yeah, it's fine. Yeah. So first we have to define fever. So many times patient's relative may complain that he's having continuous fever, or sometimes nursing staff will come and say, sir, patient is having continuous fever. But when we ask how much was the fever, so they may say it maybe sir 99 or maybe 100. So we should know exactly how do we define the fever. So the definition is very arbitrary. There are various definitions available, but in general, majority our resources says that core temperature more than 100.4 or 38 degrees centigrade, we have to consider it as a fever. And it is also recommended that we should have two consecutive temperature recording of more than 101 or 38.3. In neutropenic patient, but many times they don't elicit the fever. So in neutropenic patient, we have to be very careful, and even single rise of temperature up to 101 in absence of any obvious environmental causes. Also, our temperature elevation of 104 for more than 1 hour should alert us that patient is having something. So in general, we can consider fever of 100.4. Even IMA has also defined this as by 100.4 is considered to be fever, not less than that. So basically, normal body temperature is around 37 degrees centigrade or 98.6. Normal individual will have some diurnal variation, as we all know, and it will vary from 0.5 to 1 degree centigrade according to circadian rhythm and menstrual cycle. Even alteration in body temperature can occur with the many biological processes, specialized matrices. Many times in ICU, if patient is having shivering, or post-operative patient, we give a lot of blankets, which can give rise to rise in temperature. Sometimes patients are flashed with a hot light. Sometimes AC temperature may not be adequate. Patient on CP, means cardiopulmonary bypass, peritoneal lavage. Even patient ongoing hemodialysis and CRRD, because fluid temperature, what we are perfusing, may be little high, which can give rise to fever. So so after definition, which is the gold standard of temperature measurement. So that gold standard of temperature ideally is, as we all know, thermistor of PA catheter. So that will give accurate core temperature. Thermistor in urinary bladder almost as good as PA catheter, and esophageal probe in distal third also provide quite accurate reading. But as we all know, all these are not practically measured to the patient, so we can't just deal with this kind of devices unless we have cardiac output monitor or probe in the bladder. But these are not practical things, as we know. So sorry, this I'm just moving ahead. Previous slide.
These are moving forward actually.
No. Yeah. Okay. So then there comes a rectal temperature. So rectal temperature is also one of the very accurate temperature. It is either mercuric or electronic probe. It is generally marginally higher than the core temperature, But as you all know, again, this is not very practical. It is uncomfortable to the patient. It is intrusive. There is small risk of trauma or perforation and problematic in patient who is coagulopathic neutropenic, and it may spread the infection, particularly Clostridium difficile infection. So last is oral, which is safe, convenient, but it has got its own limitation. Temperature may be altered after hot or cold fluids, mouth breathing, heated gas, and it can damage the oral mucosa. When already damaged mucosa because of trauma, surgery, cancer, or cytotoxic drug, and it is difficult in intubated patients. So then comes I think this is more common in pediatric population where tympanic membrane measurement is also there. It reflects the hypothalamic core temperature, but it is painful in awake patients and risks trauma to tympanic membrane. So ultimately, most accurate is pulmonary artery thermistor, urinary bladder, and esophageal probe and rectal probe, but these are not very practical. Other acceptable method in order of accuracy is oral probe or infrared ear thermometry. And in adult, at least generally we see in ICU with the auxiliary thermometer, which is not very ideal, but then we don't have much alternatives. So sometimes if patient is cooperative and patient, we can give a thermometer to that single patient, means disposable, and then we can use with the oral. That is the most practical solution. Though we are not doing it in our ICU, we are doing it with the auxiliary only. So once we define the fever and the site of measurement, then when should we start doing all the investigation trigger for the fever assessment? So generally it is considered when 101 degree Fahrenheit for at least 1 or 2 hours continuous. In that case, we have to consider that now we should definitely consider evaluation. So, but generally many times what we have seen in many of the ICUs, just blanket investigation, pan culture, in the sense blood culture, urine culture, tracheal secretion culture, everything goes once one spike of fever, and also sonography and X-rays are demanded. But I think we have to go on case-to-case basis. We have to be very careful not going for all kind of blanket investigation, because it gives a lot of cost to the patient, also discomfort to the patient. So again, whenever I take any talk on fever, I will also demonstrate or illustrate the condition in which there can be inflammation or infection, but there is no fever. So it is very important in at least adult population, geriatric population, where we have to suspect inflammation without having fever. So, what are those patients? So old age patient with open abdominal wound, because the heat will be dissipated from the open wounds. Patient with large area of burns, patient on ECMO or CRRT, means continuous renal replacement therapy, congestive heart failure, end-stage liver disease and CKD. Those patients will have very low immunity that they will not elicit the inflammatory response, and they may not have fever at all. And of course, patient on NSAIDs will not have any kind of fever. So again, we have to consider infection in absence of fever, where if some of these criteria are there, like if patient is with unexplained hypotension, this is very common in immunocompromised patient. Unexplained tachycardia, confusion. So elderly patient comes with confusion. Like I would say that patient of pneumonia comes with the confused state and some kind of hypotension without fever. Patient may have just rigors. Patient may have respiratory manifestation. In patient already there ICU, suddenly patient start developing oliguria, then it may suggest in background sepsis ongoing. Patient may have lactic acidosis, more than 2 lactate. If we found that explains that patient may have underlying sepsis. Of course, leukocytosis, leukopenia, more than 10% band cells, and unexplained thrombocytopenia. These are all possible manifestation of underlying sepsis. This slide is very important. So there are tons of causes of non-infectious causes of fever in ICU. So not all the infections, not all the fever in ICU is because of the infectious causes. So an inflammation at any places will give rise to fever. So particularly this is possible when reaction to medications, reaction to blood products. It's fairly common to have fever after giving FFPs or PCVs. Collagen vascular diseases like SLE, rheumatoid arthritis, vasculitis, then microcrystalline arthritis like gout, pseudogout, post-pericardiotomy syndrome, pancreatitis. So pancreatitis is such one condition in which there won't be any kind of infection, but it's just inflammation to pancreas, which give rise to fever. And generally, first 2 weeks of pancreatitis, we don't recommend to give any kind of antibiotic, because ultimately this patient may require antibiotic later when there is infection in the pancreatic tissue itself. So another some vascular condition like DVT, pulmonary embolism. So these are the condition in which patient may have fever without infection. So dissecting aortic aneurysm, mesenteric ischemia, colitis, these also give rise to fever. So some patient in our adult ICU CNS like IC bleed without any infection or aspiration pneumonia, that also can give rise to fever. Suppose some patient is having trauma and there is patient is bled to retroperitoneal, so that also can give rise to fever. Similarly, hemarthrosis or blood in the lung, adrenal hemorrhage will give rise to fever. Even myocardial infarction also will give rise to fever. And then there are some metabolic conditions like heat stroke, malignant hyperthermia secondary to anesthesia. So whenever patient is post-operative, immediately fever comes, we have to consider that patient may have been exposed to anesthetic agent like all halothane, sevoflurane, all can give rise to fever. And one particular drug, choline, succinylcholine, which also can give rise to NMS kind of neuroleptic malignant syndrome kind of fever. Hyperthyroidism is one cause when many times patient is not becoming afebrile, and when we investigate an underlying hyperthyroidism may be discovered. Adrenal insufficiency, alcohol withdrawal. Yes, this is very important cause. Some patient has come to the ICU for some reason and now patient is not having any kind of alcohol. So that withdrawal will give rise to hypertension, tachycardia, fever. Even seizure itself also will give rise to fever. So many times patient comes with status epilepticus in our adult ICU and patient may have fever 6 hours later. That is because of muscular activity of the during the seizure. And some all malignancy, particularly lymphoma, renal cell carcinoma, hepatocellular carcinoma also can give rise to fever. So we have to consider whenever there is fever, infectious versus non-infectious fever. So this is very important. Unless we find a source of infection, we just can't bombard patient with the antibiotics. Of course, there are infectious causes of fever, as we all know, and this is one of the most common cause like UTI, pyelonephritis, prostatitis, vascular devices. This is very important, like phlebitis. One of the very important causes in adult. Generally, we recommend to change our IV access at least 3 to 4 days, and we always every day we look after the IV access site in the sense of it can be thrombophlebitis. Similarly, we put intraarterial line which also can give rise to bacteremia and fungemia. Of course, patient on ventilator, patient can have tracheobronchitis, ventilator-associated pneumonia. Sinusitis is also one of the important causes. Empyema, lung abscess, surgical-related wound, of course, wound infection, deep-seated abscess, skin and soft tissue. This is very important. Decubitus ulcer. Decubitus ulcer, patient is long-term bedridden, then patient can have what we call commonly is pressure sore or bed sore. So it is also one of the important things. Even gastrointestinal cause, if we consider antibiotic associated colitis, is one of the important cause. So patient on prolonged antibiotic can give rise to colitis, ischemic colitis. Then one of the important causes is cholecystitis and cholangitis. And then all the hepatitis, cytomegalohepatitis C or B, intraabdominal abscesses, diverticulitis, and prosthetic valve infection, like patient is having pacemaker in situ and that can got infected. Patient can have infection in the joint. When patient on CAPD, like continuous ambulatory peritoneal dialysis, that can give rise to peritonitis and can give rise to infection. Patient is having intraventricular shunts, so that patient like the shunt gets infected, or patient is having external ventricular drain which can give rise to infection. So these are the common causes. So let's come to the evaluation. So when patient is having this kind of fever, history and physical examination becomes most important thing. So when we have to examine patient from head to toe, and whenever there is any localizing sign or tenderness or discharges, that particular site can be a source of infection and fever. We have to elicit the history, previous infections can be there. There can be underlying malignancy or allergy to certain medications. Then we have to always ask the nursing staff of the duration of intravascular devices, which I have already discussed. Then this is a very important amount and purulence of sputum and ET or TT secretions. So like nursing staff is telling that sir secretions low આવે છે, but then we can ask the secretions of color change થઈ ગયો છે. secretions પહેલા કરતા વધી ગયા છે, that will give some impression, and then we can consider that patient may be having ventilator associated pneumonia, or patient can be developing pneumonia in patient who is already ventilated. We have to see the wound drainage, we have to see the change in skin condition. So many times mottling can be seen, which is a sign of underlying severe sepsis, which leads to microcirculatory failure. This is also very important. So whenever patient is on ventilator, if patient's oxygen requirement is going on, patient's PEEP, that is positive end expiratory pressure requirement is going on, that denotes that underlying patient's lung is worsening, and possibility of, along with this, if there is fever, then we have to consider that patient is developing ventilator associated pneumonia. Abdomen is always like a Pandora, and then patient can have diverse of condition in abdomen which can give rise to fever, like cholecystitis, diverticulitis, intra-abdominal abscesses, diffuse peritonitis, ischemic bowel, and colitis. And this is examination of genitalia, unsuspected epididymis. Recently we had one patient which patient came with severe hypotension and renal failure, but patient did not have any fever. And when patient was resuscitated and after patient became little better, he told that patient is having severe pain in the scrotal region, and ultimately we found that patient was having torsion of testes with sepsis. So this way, we can't neglect any of patient's symptoms. So prostatic abscess, pyrerectal abscess. Pyrerectal abscess is really difficult to diagnose unless we turn the patient and examine that, trace that particular point. It is really going to be difficult to diagnose this kind of infection. We have to examine the skin for drug reaction, skin necrosis, changes of vasculitis or endocarditis. Whenever we have intra-arterial line and central all the vascular devices, we have to see whether any pus discharge is there from the exit side or not. Examine wound post-operatively. Fundoscopic examination is very important, like patient is having systemic fungal infection. If we do a fundoscopic examination, it may give our signs that if there is a fungal infection in the eye, which is a sign of systemic fungal infection. And look for sign of sinusitis. When patient is having Ryle-Staph since long time, or patient is intubated nasally, it will block all the sinus openings, which can give rise to sinusitis. So this is very neglected and underdiagnosed cause of fever in the ICU. So in diagnostic study, we start with always blood culture and appropriate culture from clinically suspected site. Like if patient is intubated, we can have endotracheal or tracheal secretions. We can consider going for bronchial or lavage urine culture. So this we have to be specific according to site of infection which we suspect, rather than going for a pan culture. Patient is suppose sterile culture of ascitic fluid required if patient is having cirrhosis with ascites. If we suspect meningitis, or if patient is having already EBD drain, then we can take CSF for the same. Or pus culture for debridement joint aspiration may be required if patient is having tenderness in the joint. Of course, X-ray, chest, and ultrasound, CT scan, MRI of the local site is required. Now, and of course, we have to always go for CBC, LFT, RFT, amylase, lipase, lactate, thyroid profile, and free cortisol level. One more important slide I would like to just highlight is that always we have to correlate this. We have to always do CRP and procalcitonin. But there are pros and cons of doing CRP. We should know when CRP will be high and when procalcitonin will be high. So if we see the properties, acute phase CRP is acute phase protein. This is homokine. Maximum peak is around 50. Normal values CRP is more than 0.08. PCT is nanogram. Source is liver, and this is procalcitonin virtually all cell and macrophages. Now this time is 4 to 6 hours, here 3 to 4 hours, so not much difference. But peak will be almost after 2 days for CRP and around 24 hours for procalcitonin. Now the important confounder, which is important, when patient is on steroid, CRP won't be affected. Like if there is rise in CRP with steroid or immunosuppression or neutropenia or renal failure or renal replacement therapy, that denotes underlying infection. While procalcitonin will be falsely negative when patient is on steroid or patient is on immunosuppressants or patient is having neutropenia. So any neutropenic patient, if ECD is normal, that will not rule out the underlying infection. So again, renal failure, CRP will not be affected, or PCT will be high. So high PCT when patient is having renal failure will not always suggest you of infection. And when patient is on renal replacement therapy, like patient is on dialysis, the PCT will be falsely negative. So these are important things. So important thing about the CRP in CKD, chronic liver disease patient, it will be very much reduced. So normal CRP in liver disease patient will not rule out the infection, while PCT will be raised. So similarly, in acute liver failure, there won't be CRP rise. So this is also very important. So whenever there is acute liver failure, we have to consider going for PCT. So when patient is having secondary, like patient comes with pneumonia, patient is doing well, and after 10 days, patient is having secondary infection. At that time, CRP and PCT values may not be elevated too much. So we have to go very much clinically. And it will not differentiate both of these things will not differentiate much about CRP and PCTs. Viral and bacterial infection. So it is said that PCT is very important to differentiate between viral and bacterial infection, but it is really not that much as per majority articles. PCTs also will not be that much helpful to differentiate it from the bacterial pneumonia. So there are some pitfalls of PCT, which includes falsely elevated in trauma patient. After major surgery, PCT will be elevated. In multi-organ failure and myocardial infarction also we can have rise in PCT. So this we have to keep in mind. Some slide about the blood culture, which is very important. So whenever blood culture is taken, we have to be very careful. How do we collect and how much do we collect? So it is recommended to do a skin preparation with 2% chlorhexidine with 70% alcohol. This is the recommended solution for skin preparation. If we are also taking from IV access device, then we have to clean the stopper device with a 70 to 90% of alcohol. 10% povidone means betaine is effective but not as good as this combination. And volume 10 to 20 ml per set and 1 to 3 ml per set in pediatric population. And such 2 to 3 sets from different sites, 30 to 60 minutes apart, we should collect. So these are some recommendations. Try and obtain before administration of antibiotic blood culture. In case of periodic chills and fever, try and collect at the time of that particular episode. So then we have more chances of growing some positive culture. Obtain 3 to 4 sets, never less than 2 sets. So at least one set aerobic and other anaerobic bottle. And if we are suspecting fungus also, then we can, though this bottle will definitely grow the fungus also, but if we suspect very high suspicious, then we can take a separate fungal culture bottle. And when we have peripheral line, center line, we should always collect one set from the central line to rule out any CRBS, I mean central line related bloodstream infection. And it should be labeled like at what time you have collected, write the date, time, and the site from which it has been collected. So now we come to one by one other, like intravascular devices infection. How do we rule out? Inspect daily. Look for changes of thrombophlebitis. Look for any pus or exudate near the entry site of the central line. And when do we suspect central line infection? If we have collected 2 sets of blood culture, if the blood collected from the central line become positive 2 hours before the blood collected from the peripheral or peripheral puncture, then probably it 100% denotes that patient is having central line infection. There are various other matters like semi-quantitative, quantitative method, which is difficult to discuss here because it's going to be very lengthy. If there is a sign of septic shock or embolization, then line should be removed. So now one more important thing nowadays is available BioFire blood culture ID2 panels, which can identify 43 target in one test in about 1 hour. So this is available in majority good laboratory like Toprani lab. So we collect blood culture, and then if they have this BioFire panel, it can give rise to at least identification of majority 43 organism in just 1 hour, or at least we can have TAT of means type. At least same day we can have at least identify the organism. Though sensitivity won't be detected, because for that we need to go for our traditional culture sensitivity method. It will identify this much bacteria, Acinetobacter, Bacteria fragilis, all enterobacterials including Klebsiella pneumonia, even Salmonella, Haemophilus influenza, a lot of fungi. Even it can detect the carbapenem, which is very important. So we can identify this patient probably is resistant to carbapenem. Uh, it also identify a lot of enterococci, staphylococcus. It will identify ESB as methicillin resistance, vancomycin resistance. So this is very important. So little bit about ICU-acquired pneumonia. So whenever patient is in the hospital or intubated, after a few days, if patient is running fever and if we suspect that patient can be having pneumonia, then uh, we have to basically ascertain diagnosis by doing X-ray chest. CT scan not always practical, but when patient is immunocompromised, like patient is of HIV or patient is having on patient or immunocompromised drugs, sometimes secretions what we give will not be a good idea to identify the underlying organism. So CT scan may give some idea because patient can be having atypical infection. Respiratory secretions, if patient intubated, then we can send secretions, Gram stain, KOH stain, Gomri stain. Gomri stain is basically helpful to identify pneumocystic jerovic infection. We can consider doing BAL, which is very helpful in immunocompromised patient to identify like CMV, nocardia, Mycobacterium tuberculosis, aspergillosis, mucor, or PCJ. But many times suppose some patient is having copious secretion and we have sent it for the culture and it is growing something. But if patient is not having fever, patient is not having oxygen requirement going up, so it may be a colonization. So we don't treat the colonization. We have to differentiate between colonization and infection, and it is very important because we don't bombard with the antibiotics in that cases. And we have to correlate, we have to send the biomarkers, we have to see whether patient oxygen requirement, PEEP requirement going up, patient is having fever, whether patient is immunocompromised or not. If pleural fluid is there, then definitely we can aspirate and then send it for the examination. There are particularly two important urinary antigen for Legionella streptococcal pneumonia, which is very important for community acquired pneumonia. And add-on investigation, we can consider CMV, PCR, varicella, BD glucan, and galactomannan for aspergillosis and candida. So UTI is many times I would say that when patient is catheterized since long, majority time it is a colonization and not the true infection. So but in immunocompromised patient, we have to consider if patient is having hypotension or patient is having fever with bacteria has grown in the urine culture, then we have to consider patient can be having UTI. But if patient underwent any urological procedure, then patient, because urological procedure will definitely can give us a lot of bacteremia and UTIs, and we cannot neglect in such kind of patient. Urine should be collected from there is port available in the catheter from which we have to clean and then we have to collect it. And it should be processed within 1 hour to prevent multiplication of bacteria in the sample. Now, this is also one of the very important post-operative fever. So, post-operative fever can be there up to 48 hours or maybe up to 70 to 96 hours because of it's a kind of inflammation of the body. So that can give rise to fever. So, but then we have to evaluate if after 48 to 96 hours, if there is fever, then we have to identify the source, like patient can have aspiration, atelectasis, UTI, surgical site infection can be there. This is of course after 3 to 4 days. Patient can have hematoma, infection in surgical field, wound infection, very rare in first few days. But unless group A streptococcal clostridium infection is there, which can give rise to fever in very early days also. We have to rule out other causes: phlebitis, pulmonary embolism, drug fever, malignant hyperthermia, as we have already discussed. This is one very good table just to have kind of mnemonic for the post-operative fever. They consider 7 Ws like wind atelectasis, less than 48 hours. So treat with the incentive spirometry, pulmonary toilet, early mobilization. Pneumonia after 48 hours. UTI can be there after 48 hours. SSI can be there after 72 hours. Then DVT means walking after 72 hours. We have to do venous Doppler, bilateral whole in venous Doppler to rule out DVT. Wonder drugs like medication also can give rise to fever. This I already discussed that delirium tremens. So after 72 hours. So we have to review the patient history, administer benzodiazepine, consult the psychiatrist. Wonky glands, adrenaline insufficiency. Also, can less than 12 hours it can give rise to fever and severe septic shock. So we have to review the patient history and medical history, administer fluid and hydrocortisone. And thyroid storm, less than 48 hours. Again, we have to review the patient history, administer beta blockers, thionamide and iodine, and consult endocrinologist. So surgical site infection examine, we have to ask surgeon to look at the surgical site at least daily for any erythema, purulence, tenderness. If we suspect that patient is having infection, open and take the culture from the wound if clinical suspicion is there. And I would prefer to do either biopsy or aspirate the pus instead of just taking the swabs, because swab will be more of colonizer. So we can get ICU bacteriflora from the swab. So if we take it from very deep space, or if we take the pus, that it will be a true infection. So then CNS infection, if altered sensory or focal deficits are unexplained with cure, do CSF if there is no contraindication. If mass is present, we have to consult neurosurgeon or physician before CSF. Suppose some patient is having intracranial bleed and patient required external ventricular drain, or patient is already having Omaha reservoir. Omaha reservoir is basically when patient is having hydrocephalus. Sometimes they keep it so the extra CSF will be collected in Omaha reservoir, and if you want to examine, then we can aspirate from the reservoir also. And if patient is having external ventricular drain, we can take a CSF from that. And always send CSF for pyogenic HFA, PCR and cryptococcal antigen. So I have already discussed this. Nosocomial sinusitis is difficult to diagnose, often overlooked. Suspect in patient with no other cause of fever. When we can't find any other source, we consider, particularly patient is having nasal intubation, prolonged Riles tube or facial-maxillary trauma. Diagnosis is by CT scan, and we can give empirical antibiotic. But if there is no response to empirical antibiotic, we can puncture and aspiration of involved sinus, and we have to send it for the pyogenic and fungal culture. Now, again, diarrhea and secondary clostridium difficile infection is very important if patient is in the ICU and patient is on the antibiotic since patient is on antibiotics since many days. Then patient can develop pseudomembranous colitis or clostridium difficile infection. So majority patient, my experience is that this kind of patient will have a lot of leukocytosis and patient may have abdominal distension. So any antibiotics can give rise to this kind of infection, but particularly clindamycin, cephalosporin, and fluoroquinolones are more common. Patient will have diarrhea. We can send enzyme immunoassay for toxin A and toxin B, and suspect when only had toxic megavolumine leukocytosis. And sometimes this patient may require colonoscopy just to visualize that pseudomembrane, and patient may require biopsy. In patient of cancer or stem cell transplant, neutropenic enterocolitis or typhlitis can be the cause. And stool cultures are not always required because a patient can be again colonized with the ICU flora. So if we are suspecting Clostridium difficile infection, then we have to send toxin A and toxin B, or clinically we have to chlorinate. So other causes of infection include otitis media, decubitus ulcer, which is very important. When patient is long-term bedridden, then patient can be having bed sore which is infected, which can give rise to. So always have a habit of turning the patient at least alternate day and see from head to toe whether there is any tenderness anywhere or there is any pus discharge from any place. Always at the same time we have opportunity to see the back of the patient and we can identify any bed sore is there. Again, perineal abscess, we cannot identify unless we palpate those things and unless we turn the patient around. Undetected retained tampons, which is not very common nowadays. And infectious mononucleosis is very rare cause, but it is possible after transfusion of CMV infected donor. So reactivation of CMV after antigenic stimulation is also possible. It may be self-limited disease to life-threatening complication in immunocompromised patient. So it should be suspected when there is spiking with no response to antimicrobials, all cultures are negative, and there is a history of blood transfusion, and thus pancytopenia with atypical lymphocytosis and mild elevation of LFT. One of the very important and difficult to diagnose thing is drug fever. So patient can have fever because of hypersensitivity, which can happen with any drug. Patient can be a local inflammation, phlebitis, sterile abscess, soft tissue reaction. So this amphotericin B, KCl chemotherapies can give rise to phlebitis. Amphotericin B can give rise to chills and rigors while administration. Sometimes the 100 ml NS with which we dilute can or diluent can have pyrogens. Some drugs will limit the heat emission like atropine or epinephrine. So many times OP poisoning patient we give atropine infusion. Patient after 48 hours patient can have high grade fever. So it's because of the drug atropine. And alter thermoregulation like antihistaminics, anti-Parkinson drug, butyrophenone, tranquilizer, and phenothiazine can give rise to fever. So common drugs causing fever is antimicrobial is one of the very common cause like beta-lactam. Anti-epileptics include phenytoin, anti-arrhythmics like quinidine. And fever may come up to 21 days after starting the drug. So there is no specific pattern. It is diagnosed by starting or stopping or re-challenging the drug. So if patient is having severe reaction or severe anaphylaxis with the previous drug exposure, then we should not re-challenge. But if patient is having just fever, then we can stop and see if patient's fever subsiding. Then we can consider that definitely it's a drug fever. As I already discussed, withdrawal of certain drugs like opioid, benzodiazepine, alcohol can give rise to fever, tachycardia, diaphoresis, and hyperreflexia. Many patients in adult population are tobacco chewer. So simply by just withdrawal of tobacco also can give rise to severe delirium, and that can give rise to fever also. Last few slides we have in which fever management. So whether antibiotics are required or not, if infectious cause is there, we have to control the source and we have to give the antibiotics. Now, effect of fever. Now, I would many times says my ICU registrar or nursing staff that not always necessary that we give paracetamol for the fever fever abatement, because fever may have protective effect like boosting several aspects of innate and adaptive immunity. It inhibits the microorganism growth, it slows the viral replication, and it augments the antibiotic efficacy. Particularly, but we have to treat fever in certain cases like cardiac cases or in case of neurological cases where patient may deteriorate because of the fever, because it increases the metabolic rate, it increases oxygen consumption, it adversely affects the cardiac function, and it may be detrimental in septic patient with further aggravating tissue hypoxia. So I would treat fever when patient is neuro patient or patient is having cardiac, like patient is known case of ischemic heart disease. But otherwise, if patient is young patient is stable, then probably we can just wait and watch. Unless relatives are very panicking, we can definitely console them that fever is not going to be detrimental unless patient is having severe shivering or patient is definitely having oxygen requirement going up. Unless that thing occurs, we can just observe the patient very closely. One more thing which we have observed in adult population, that many times after giving paracetamol high dose, it can give rise to severe hypotension, systolic BP of 90 or drop more than 20% from baseline. So I would consider to give oral paracetamol 650 milligram instead of giving IV PCM because in septic patient, sometimes it is very detrimental, and we need to start sometimes noradrenaline to increase the blood pressure. And so one of the last slide is that do antibiotic therapy in critically ill septic patient. In septic patient really improves the mortality. So there were 8 randomized trial and 8 observational studies were analyzed, and antibiotic therapy did not reduce 28-day hospital mortality in randomized studies. So antibiotic treatment does not significantly improve the 28-day hospital mortality in adult patient with sepsis. So I would consider antibiotics. We can do a cold sponging. We can give we can put ice packs in the axilla and groin to release the temperature, but not necessarily always give the paracetamol IV to reduce the temperature, because it is not associated with the reduction in mortality unless there are IHD or neuro cases are there. So I would end my talk here. Thank you very much, and forum is open to all the questions. Thank you.
So thank you so much, Dr. Ankur Bhai. It was so elaborate and gave a lot of idea about how to deal with fever in ICU. Can you please stop the screen sharing so that we can have more people seen on the screen?
Sure, sure.
Yes. So any question, comments are welcome now.
I would say a very important part of blood culture, I would say, is very important. Blood culture collection many times in even majority hospitals, they don't do any kind of blood culture, and then patient after 10 days fever is not going. It's really difficult for us what to give, what not to give. So if possible, at least in hypotension septic patient, we should always collect the blood culture, and that too at least 2 to 3 set, not just one set. So that will, more the blood volume we have, more chances of growing the organism, I would say this. And it is to be done very meticulously after cleaning the skin, preparation properly, so that we can have minimum kind of contamination.
Right. Any comments from physician or other intensivist in the audience? So I think there are no questions. So we can end the session here. And thank you so much, Ankur Bhai, for once again coming to this forum. And a special thanks because I gave you a very short notice because the other speaker couldn't make it today.
No problem, sir.
So thank you so much for agreeing on a very short notice.
Thank you.
Next Saturday, we have Dr. Saurabh Bhomik. He will be talking about deep pain stimulation. So an interesting topic again. So we meet next Saturday. Till then, goodbye. Thank you.
Thank you,
Thank
sir.
you all. We end the session here. Thank you.
Thank you.